welcome to the second episode of Hybrid Healing Hour. Today, we are going to discuss understanding lab work. So, in this podcast, we're going to oversimplify things for the vast majority of our patient population and listeners out there to understand concepts that might be very complicated. So, I think let's start with reference ranges.
In the foundation of our practice is lab work. Everything we do is based on lab work, and plenty of patients get lab work from other doctors. They bring them to us, or they look at the lab work that we do in our office, and they see the reference ranges. So reference ranges are those numbers on the right side of most lab tests that tell you where the average person falls. But that's not the same as optimal.
Exactly. So throughout this podcast, I think we'll talk about a few labs that we have optimal levels for, and we will start now.
So basically, what do you think are the most common labs that most patients are getting from their primary care doctors or from the doctors in general?
Basic. So I think that will start with a CBC, which is known as a complete blood cell count.
Right, and that can tell you if you're anemic or if you have a high or low white blood cell count or platelet count, but otherwise doesn't give a lot more information than that.
Right. Also probably a BMP, which is also known as a basic metabolic panel. If we're lucky, you might get a CMP, which is a complete metabolic panel, and that includes liver enzymes. But otherwise, this basically looks at your electrolytes, your kidney function, and a CMP also shows your liver enzymes.
And then they can get cholesterol done, which is usually a basic lipid panel. And a basic lipid panel includes a calculated LDL, right?
Tell me more about the calculation. Can you explain that for us?
Yeah, so a calculated LDL is how we've been doing it for years. They typically use an equation called the Friedewald equation, where they take the total cholesterol and they subtract from that the HDL plus the triglycerides divided by 5. So now what that takes into consideration is that if your triglycerides are abnormal, then your LDL is going to be abnormal. So it does not give you a true representation of LDL, where now we can do direct LDL.
Right. And so along with that, the calculation, when people have high triglycerides, sometimes you can get an LDL that says unable to calculate. You can't even get a result unless you go fasting.
Right. And once upon a time, people only got the total cholesterol checked. At least now, people are getting a little bit more than that. Mm-hmm. And then thyroid. A lot of people are concerned about their thyroid, but are we actually measuring the thyroid?
Not quite. So most people get a basic TSH checked, which stands for thyroid stimulating hormone, and therefore that is not coming from the thyroid. It is actually a brain hormone. So it's, there to stimulate the thyroid, but it's not showing the full picture.
Exactly. It's like a thermostat. It tells you if the thyroid is high or low, and then it tries to adjust. And then some people will have a urinalysis done, which typically is just going to either be a urine dip, which you just look for simple things like ketones, blood, things like that. And if someone is sick or having symptoms, they may get a urine culture done. But that's typically it for what most people have done at their doctor's offices, right? And we just went over that in, 2 minutes?
Right.
And our typical lab reviews are 30 minutes, so there's a lot more. So what's some of the barriers? One of the barriers of having these lab tests done is they can tend to be expensive, and they can tend to not be covered by insurance. But, you can't always be penny pitching when it comes to your health. You really want to know what's going on with you. And so just because a test is not covered by insurance doesn't mean that the test is going to be expensive. There are ways to get these tests for reasonable amounts of money, and there's so many tests available. We're going to talk about some of them, but we can't possibly go into detail about everything that's out there. So we're going to fly, and it's going to be basic, but we can, in the future, try to expand on some of these concepts.
So let's talk about preventive cardiology, and why do we do certain blood tests in that subject matter?
So if you look at what you're most likely to die from or be hospitalized from, it's probably going to be heart disease. Atherosclerotic heart disease is probably the number one killer in the United States, and the numbers aren't really getting better. I mean, they're staying about the same. So there's so many things we can do to predict who's going to have a heart attack, who's going to have a stroke. There's no reason for someone to wait until they've had an event before they start doing something about it. So what are some of the tests that we check?
Well, I was going to kind of chime in on that. So when you talk to, I think, a typical office, they're going to check an EKG and some more diagnostic testing. But what we found is blood tests can be pretty accurate markers and help guide us onto the necessary further testing that is needed.
Many cardiac events are predictable.
So we like to put out fire, or we like to prevent the fire, but not put out the fire per se. So we do some of these testings, such as what we call Lp(a), also known as lipoprotein A. This is a good, mostly genetic marker that is, I guess the best way to describe would be as if you have a tail or a hook attached to your LDL particle, and therefore this is not a good thing. This is what can damage your arteries worse than a typical LDL particle that might just be bouncing around.
Exactly, and it's not uncommon. I mean, I don't think there's a single day where we don't see at least one or two patients who have high Lp(a). Lp(a) is something that I think that every patient out there, everyone listening, should have checked at least once. It's largely genetic. There's nothing you can really do about it diet-wise yet. Medication-wise are coming, but diet-wise and lifestyle-wise, it's very little that can be done to modify this, but it's something you need to know. If you have a family history of heart disease, especially, you should be getting your Lp(a) checked. If you have high Lp(a), your children should be getting it checked. And it's so uncommon to have it checked that until recently there wasn't even a diagnosis code for high Lp(a). Luckily, there is an ICD-10 code for it now.
And it is known as, finally, I think we're seeing this now, as an independent risk factor for heart disease, regardless of what your cholesterol looks. You could have perfect cholesterol, but if you have high Lp(a), you are still at risk for cardiovascular disease.
And then when it comes to checking the cholesterol, there's cholesterol particles. Particles play a key role. You have an analogy for particles.
Yeah, I like to use the tennis net analogy. So I think of particles. They could be big and fluffy, or they could be small and hard, kind of like golf balls. And so if we picture a net, kind of like a tennis net, and you're throwing or hitting a bunch of tennis balls against the net, they're going to most likely be bounced off and continue bouncing around. But if you throw a bunch of golf balls at the net, they're small enough they can get through the net and go to the other side. And therefore, think of it as these tiny small particles can be hard, and they can get into the arterial walls and cause hardening and stiffness, which are more at risk than the small or the larger fluffy particles.
Exactly.
And so therefore, the more you have in an area, the smaller they are.
Yeah, so most people don't understand that when you're getting your LDL measure, they're pretty much taking the weight of the LDL. So big, fluffy particles that weigh exactly the same as small, dense particles are not equal. Mm-hmm. The small, dense ones are much more damaging.
So one test that I find very interesting, and I want you to tell us more about, is the ApoB / the ApoA1 ratio.
So that is another test that measures the balance between good cholesterol and bad cholesterol. So the ApoA1 is kind of a measurement of the HDL and the good cholesterol, and the ApoB100 is the bad atherogenic cholesterol. So you want that ratio to be less than 1, considerably less than 1. So in men, you want it to be under 0.77, and in women, you want it to be under 0.66. And that is a good measurement in certain populations, especially Southeast Asians. They tend to have abnormal ratios, and their risk is considerably higher than the general population.
And tell us about TMAO.
Okay, so TMAO is very interesting. It's something that people probably have not heard of before. TMAO is a substance that is produced in the intestine by bacteria. There's certain bacteria that will convert things like choline, lecithin, carnitine into this TMAO, which is toxic, and it's cardiotoxic, and it has so many effects on our health. When we find that someone has high TMAO, we recommend that they limit their intake of red meat, full-fat dairy, and egg yolk. So it's important if you're on a carnivore diet or if you're on a ketogenic diet that's high in fat, you want to know, do you have high TMAO? Because if you do, you really should not be on that diet.
And correct me if I'm wrong, I believe this is also possibly linked with colon cancer.
I think there are some links out there. We use it in our practice largely for cardiovascular health.
Right. Okay. And another one that we check, and I'm a fan of, is the HSCRP. That's a high sensitivity CRP, or C-reactive protein. This is a inflammatory marker that's produced by the liver in response to inflammation.
Exactly. And so typically when we're using it for cardiovascular health, we want to see reactive protein that's maybe under 1. Typically, when you see it from the range of 1 to 3, that could be an indication that there's heart disease. Plenty of times we see them much higher than 3, like 8, 9, 10. And that's a sign of systemic inflammation usually. And so you need to find out where's this inflammation and what can we do to bring that inflammation down.
Some other inflammatory markers we're finding interesting in the now cardiovascular aspect is uric acid and homocysteine.
Right. So uric acid, for years, people who have gout know what uric acid levels are, what their levels are. But it's not just for gout. We have found that even people who've never had gout who have high uric acid levels, that is strongly correlated with atherosclerotic heart disease, stroke. There's many things that uric acid is detrimental to. So we want to know what your uric acid level is and figure out a way to bring it down if it's too high, whether it's with diet or whether it's with medications.
Mm-hmm. And homocysteine is something that we check because, as we talk about later in this podcast, we link that with a genetic polymorphism known as MTHFR. So homocysteine is also an amino acid, I believe.
It is, and it's another independent risk factor for heart disease. It has been shown to be damaging and linked to heart disease.
Yes, and blood clots. And so therefore it can just damage the lining of the arteries. And so we actually have optimal levels of less than 10. And ideally, I think under 8 is better.
And we also have a test called LPPLA2, which is also known as the plaque test. That's a test we use more as another risk factor, right? If someone has a high LPPLA2, then that tells us we need to look more and see if there's something going on. Do they have heart disease? Do they have atherosclerotic disease?
So what's another good test that we can do to follow up with that? If somebody consistently has high LPPLA2, is there imaging that you'd recommend?
Sure. We are big fans of the coronary calcium score. We send a lot of people for coronary calcium testing, and it's a relatively inexpensive test. I think it's a great marker for people who have a family history of heart disease or have any of these lab tests that we talked about being abnormal. Mm-hmm. And another one that we don't use all the time, but we do use it frequently, is the small dense LDL. Small dense LDL, also known as SD-LDL. That's when the LDL is exposed to sugar. And a lot of times we can use that test to see if someone has a very high carbohydrate intake.
Great. So that kind of leads into the next topic of metabolic labs. And I think everybody has probably heard about the hemoglobin A1C. That is your 3-month blood sugar average, and it comes in a percentage form. Unfortunately, I've heard of many physicians not checking this anymore, and I just find that absolutely shocking, quote unquote, because insurance doesn't cover it. But we have diagnosed many people with metabolic syndrome or insulin resistance by checking this regularly. And so the hemoglobin A1C, like I said, is a 3-month blood sugar average. And when it is 5.7, you're considered prediabetes or insulin resistant. And when it gets up to 6.5 or higher, that is the diagnosis of diabetes.
Right. But we know now that once you've reached 5.7, you're already having some issues. Your beta cells have cranked up the insulin production to keep that A1C where it's at. In my opinion, there's really no such thing as prediabetes. You're either diabetic or non-diabetic. Sometimes you're just a diabetic who hasn't shown himself yet. And I just don't understand not checking hemoglobin A1Cs until someone has a diagnosis of diabetes. And that's really what's being done most of the time.
But then that's what I find so interesting. How do you know if they're diabetic or not if you're not checking it?
Exactly.
You know, it's just mind-blowing. The next one is cortisol. Why don't you go ahead and tell us about how cortisol is checked?
So cortisol is a hormone produced by our adrenal glands, and it's a stress hormone. So we can do a random blood cortisol level. Now, cortisol is one of those hormones that fluctuates throughout the day, like many hormones do. It's highest in the morning and it's lowest in the evening, and it should follow a pattern. So when you do a random cortisol, you have to say, well, is this a morning specimen? Is this an afternoon specimen? And with the random cortisol levels, we can only tell, is it too high or is it too low? What we like to do is serial cortisol levels, where we check someone every 4 hours or every 6 hours. And that can be done through saliva, so they don't have to physically come in the office and have their blood test done. And saliva is very accurate. And as long as you collect it correctly, it gives you a great graphic representation of how they are throughout the day. And you can tell if people are overstressed, if people are not leading healthy lifestyles, their cortisol balance will be way off.
And we're going to get to another test later that also checks cortisol. All right, so IGF-1, I like this one. This is your insulin-like growth factor 1, and this is something we check in our office as an overall wellness marker. We have found that there are definitely optimal levels, and we don't really go off the reference range with this one. It is linked with your growth hormone and development, but
it's become very popular now to take growth hormone analogs. I mean, once upon a time, people were taking growth hormone, but that's very expensive and that carries some risk. But the growth hormone analogs have become very popular and very effective. We use them in our practice as well. And IGF-1 is a good way to kind of track who would benefit from it and how people are doing while they're on it.
And it's also linked with anti-aging.
It is.
All right.
Another hormone that is relatively new and probably many people have not heard about is adiponectin. Adiponectin is a good hormone. It's produced by the fat cells, and it helps with several different things, with fat burning, with insulin resistance.
It helps with helps the muscle metabolize the carbohydrates, and so it can definitely boost your metabolism. So
people on weight loss programs should be getting their adiponectin measured.
Urine microalbumin. This test, I think, is becoming more known with the newer medications that are out these days. Chronic kidney disease is becoming a prevalent, unfortunately, a prevalent diagnosis throughout the nation. And urine microalbumin can check the amount of protein in a urine. And so we see this a lot with people who have insulin resistance or diabetes or uncontrolled hypertension. So this is something that should be checked, I would say, at least twice a year, and especially if you have those diagnoses.
Exactly. And for the longest time, kidney disease was only diagnosed by blood testing. But we know now you can have a normal serum creatinine and still have kidney disease if you're spilling a lot of protein in the urine.
And speaking about that, why don't you tell us more about cystatin C? I think many people aren't aware of that one.
So in the past, the blood test that was largely used for testing renal function was creatinine. And creatinine is dependent on many factors. It's dependent on your muscle mass, your age, and so we have different levels for normal creatinine values. Now we have cystatin C, which is a little more accurate. And when we have people who maybe big muscular guys or really thin, frail people, we'll check a cystatin C in them as well. And it can detect kidney disease or can detect someone who doesn't have kidney disease when the creatinine was abnormal.
Perfect. All right. One of my favorite topics, hormones. So we check hormones, and I think we check a lot of different hormone levels that are not in the standard because we also take care of women with hormones. So tell us how testosterone should be checked in both men and women.
So it's interesting because I can guarantee that many of the women who are listening to this podcast have not had their testosterone levels checked because for the longest time, testosterone has been ignored in women, but women do naturally make testosterone. They make testosterone at a ratio of about 10% of what men make. So it's a really important hormone for muscle development. It helps with our brains. It helps with our energy. Of course, everyone thinks of it as a libido and sexual health hormone, but there's so many benefits of testosterone, and we really think that these days we're seeing so many women with low testosterone. Now, PCOS is a diagnosis where women have high testosterone levels, or at least high free testosterone levels. So, but it should be checked. It should be checked more frequently than it is. And another thing, going back to the reference ranges with testosterone are always not what we consider optimal. We're really happy with men with a testosterone level that's around 800 to 1,000. I think that's optimal.
And with women, I think it all depends on the age. I'm sorry if you tell me. I've seen a reference range. Literally, it says testosterone reference range 0 to 70. And I'm sorry, if my testosterone is 0, that's not normal.
But again, that's what a reference range is. So it's, it's a shame. And I think that, it's telling that there is not one pharmaceutical drug that has ever been developed to help women's testosterone levels.
Nope. It's unfortunate. Moving on, estradiol. That also is a women's hormone, but men need to have it checked as well.
It's important in men and women. And unfortunately, there's a lot of men taking estrogen blockers, right? And they're knocking their estradiol levels way down into nothing. We need it. It's a hormone that helps us with our moods.
It's good for the brain.
It's good for fat burning, vaginal lubrication, but it has so many benefits. And so the good estrogen is estradiol or E2 or 17 beta estradiol. And that's the one that we typically measure.
We also check progesterone in our females, and that is the one I always relate to as our recovery and repair overnight. So for when you're complaining of not sleeping all of a sudden after menopause, or you're having hot flashes and night sweats, it can also be linked with progesterone.
It's amazing when you have a woman who's not able to sleep and you measure her progesterone level and it's zero. And then you put her on progesterone, all of a sudden she feels great. It really is a feel-good hormone.
Ferritin. Tell us about ferritin. A lot of people think of that as just an iron level or iron storage, but it can also be for inflammation as well, correct?
It is. It's it's an acute phase reactant, which means that it can respond and become abnormal in signs of other stress. But ferritin is something that is vastly ignored. When people are checking blood work for anemia, they're only looking at the CBC, which is the hemoglobin and the hematocrit. Ferritin is the iron binding protein that really we know the optimal level of ferritin is going to be, what would you say, over 55 and preferably above 80, right?
Yeah.
And we have plenty of people who come to our practice, men and women, whose levels are nowhere near that. We try to get levels above 80 for people with insomnia, people with chronic fatigue, people who just don't feel good. Ferritin level is important, and it should be measured more frequently.
And it's very important for hair.
Absolutely. Hair loss, one of the tests for hair loss should be ferritin, and the other test for hair loss should be thyroid. Which brings us into thyroid.
And as we said before, the TSH is just not enough. So TSH is the thyroid stimulating hormone, which stimulates the thyroid to pump out the free T4. And we also check the active form of thyroid, which is the free T3. So do you want to go into detail about how those work why we check those?
So TSH is a good screening hormone. It's fine for someone who's not on thyroid medication, but I have so many patients who come to us who are on thyroid medication and all they're getting checked is their TSH. You really want to check the active hormones. So synthetic thyroid hormone, which is Synthroid and levothyroxine, those are pure T4, and they depend on your body to convert them into the active hormone, which is the free T3. If you're not measuring free T3, you really can't tell, is someone converting properly or not? And consequently, when someone is on a compound that has T3, their TSH may be very low, and we expect it to be low a lot of times, and we don't necessarily need to react to that. So then there's also something called a reverse T3, which a lot of doctors don't check, and I don't know that everyone needs to have that one checked. Right. But so when you convert free T4, which is inactive, into T3, it can either be converted into T3 or reverse T3. Reverse T3 is not active and it's not really helpful for anything. But if you're converting all your T4 into reverse T3, then you're not getting enough of the active free T3 that you need.
And then another thing we like to check is, like you said, when people still just aren't feeling optimal, is their thyroid antibodies. We've been able to check like the anti-TPO or thyroid peroxidase antibody that is looking for Hashimoto's.
Yep, and antithyroglobulin antibody. Autoimmune disorders are huge now. There's so many people who have autoimmune disorders, and the most common one is probably going to be thyroid disease, especially Hashimoto's.
All right. Going back into a different type of hormone testing, this is based off of your urine and urine metabolites. The most common one I think we're familiar with is Dutch test. You may have heard this before. It's big in the functional realm of medicine. And we actually just did one recently under the physician's lab. I found this test very, very interesting. We did a urine collection about every 4 hours, and we were very limited on our water intake, which I found to be terrible. But overall, the results were astonishing.
It was, and not only that, but to tell you how complicated this test is, we actually had the luxury of having it reviewed to us by one of their clinical directors who knows this test backwards and forwards. And I know with my results alone, it was about 45 minutes for him to go through everything, and it gave us so much information. But it tells you cortisol breakdown, it tells you hormone breakdown, it tells you melatonin breakdown. Melatonin is crucial for health, and so this is a great test. But in order to have this test done and done accurately, you really need to have it ordered by someone who knows this test well and has a lot of experience interpreting this test, because it is one of the most complicated lab tests to review.
Definitely. So along those lines, another complicated test, as we get into this, we're diving into the more testing that I think is not done very often, is nutrient testing. So this is more than just checking your vitamin D and your vitamin B12 and your blood test. We will talk about that, but I guess we'll talk about the serum levels first. Yep. So talking about vitamin D levels, we have optimal ranges that we like, and we specifically check the 25 hydroxy vitamin D, which is looking at the form of vitamin D that's metabolized, and to see what's actually going into the tissues versus just floating around.
Exactly, and it's another one where the reference range is usually 30 to 100, which makes no sense at all. You want optimal levels. So really, for the 25 hydroxy vitamin D, ideally, you probably want to be around 80. Between 60 and 100 is fine. Some doctors are afraid of getting their patients' levels that high. I've never seen a problem from that. I've never seen a study that showed a problem from that. And we learned through the whole COVID pandemic that people who had higher vitamin D levels did a lot better than the people with low vitamin D levels. We think vitamin D is something that really should be checked on everybody.
Yeah, it's not just about getting the calcium absorbed for bones. We know that it is important in your immune system and hormone function as well.
Mm-hmm. And brain and everything. Then there's vitamin B12. Vitamin B12 is something that a lot of patients are deficient in. B12 is necessary for neuropsychiatric functioning. People with anxiety, people with depression, people with numbness, tingling, all those people should have their vitamin B12 levels done. And sometimes that test is not accurate. Sometimes you need to go a little bit further and check methylmalonic acid to really find out if your B12 is adequately being broken down.
Right. The micronutrient testing is what I was getting excited about. So tell us a little bit more about like SpectraCell or the Genova Nutraval, and what does that look at that's different than the serum testing?
So micronutrient testing actually checks the nutrients that are inside the cell, whereas serum blood testing tells you what's floating around in your circulation, right? So there's different concentrations of nutrients inside our cells than outside our cells. Potassium, for one. Everyone knows that potassium levels are widely different inside the cell than they are outside the cell. So with the micronutrient testing with SpectraCell, and I think Nutraval does the same thing, they take lymphocytes and use them as a surrogate for all the cells in your body, and they measure what's inside the cell. The report is beautiful. It gives you a great list of every nutrient and tells you if you're low, normal, or high. And then you can target those. And I've seen plenty of patients who've had normal vitamin D levels, right? And then you do the SpectraCell, and it's completely off. They're not absorbing it. Mm-hmm. It's a good test to test for nutritional deficiencies.
The next topic of conversation I'd like to say is the cancer testing. And we all know about our preventive care measures that we take. Women over the age of 40 go for a mammogram every year or two. And we try to do colonoscopies or a Cologuard to look to see if we have any risk or precancer colon polyps. But now there's a lot of blood tests out there that can help us. So tell us about the Gallery test.
So what are the three things that people are the most scared of? Heart attack, stroke, cancer, right? Mm-hmm. Those are the three biggest fears out there. People don't typically walk around being afraid of car accidents and falling or things like that. So we had good cardiovascular prevention screening tests, but we've never had any great blood tests for cancer. We had tumor markers out there, but now there's a few tests that are very interesting. Gallery is a relatively new test, and it's Gallery with an I, not a Y. And it tests for 50-something different cancers. The test tells you if you have cancer right now or if you don't have cancer. It really doesn't pinpoint it. It can narrow it down to a couple of different types of cancers. The only cancers it can't detect are brain cancers and thyroid cancers, but it can detect a lot of different ones based on the methylation signal of DNA. And so it's an excellent test, and people who are afraid of cancer or have a strong family history of cancer or another risk factor for cancer, it's something they may want to consider. Like with all tests, you may have false positives and false negatives, but it's another tool that you can use and then proceed further.
Well, I was going to chime in on that. So with the Gallery test, that checks to see, do you have cancer right now? We do also have other cancer screening tests out there to look to see if you're predisposed to different types of cancers. The one that we use in our office is Natera, but there's several different ones out there, including looking at the BRCA1 or BRCA2 gene testing. And then the great thing about those tests is if you do have these genetic markers saying you're at risk, then you can do certain screenings more, I guess, prophylactically to try to catch it sooner or reduce your risk. Or, obviously with some BRCA1, BRCA2, people see specialists to discuss if they should have a mastectomy ahead of time to prevent even going through any issues.
Exactly. Many people know about the BRCA testing, but they don't realize there's many, many other genes that also play a role. Yes. Another test very similar to Gallery is the Guardant 360 CTX test, also known as liquid biopsy. That's very similar to Gallery, but I think it works on a different mechanism. And of course, we already talked about tumor markers, which we don't recommend routinely, not for screening. Tumor markers really should be reserved for someone who has disease if you're monitoring the progression of the disease. And of course, for men, there's PSA. And there's the standard PSA that most people get checked, but many things can affect PSA, right?
Yes. In fact, you can, we always look to make sure that your PSA is not doubling within a year or if it's not, over 4. But there's a lot of things like exercise or bicycle riding. If you had a bowel movement before the blood test, if you ejaculated within 72 hours of the blood test, those are things that can definitely cause a false elevation.
If your PSA is high, it does not mean you have cancer. It just means that there's something going on with the prostate. So now we have newer PSA tests. We have the 4K PSA, and the 4K PSA actually measures 4 different indexes in the blood. And it's one of those tests that could make the difference between someone having to go for a biopsy or not having to go for a biopsy, right? Nobody wants to have to go for a biopsy, although they're safe now. And there's another test we use called the percent-free PSA. And the percent-free PSA is actually one that you want that test to be high, not low. The higher, the better. And so if it's under 25, then that's concerning.
Some genetic testing that we like to do in our office and is the MTHFR, stands for methyl tetrahydrofolate reductase. And this is, you get one gene from your mother, one from your father. Some people look at it as the mother-father gene. And this is frequently associated with cognitive impairment or neuropsychological conditions, depression, anxiety, bipolar, but it can also be linked with blood clots and inflammation, heart disease. As we discussed before, this can be associated with that elevated homocysteine level, and it's typically associated with vitamin deficiencies, such as B12 deficiency, B6 deficiency, or L-methylfolate.
And this is a test that many women who are pregnant or thinking of getting pregnant should have done, because we all know how important folic acid is for a developing baby, for neural tube defects and things like that. But at the same time, if you're not converting it properly, you need a different form of folic acid, which is now why some prenatals even are using L-methylfolate rather than just straight folic acid.
Yes. Tell us a little bit about COMT.
So COMT or COMT is another genetic test that also affects psychiatric health. We found that many patients who have anxiety, depression, bipolar disorder, schizophrenia, they're not having blood testing done. They're just being having medicines thrown at them. And sometimes supplements can help. Sometimes with COMT we use SAMe, but I think it's a good adjunct especially for anyone with any kind of psychiatric diagnosis.
And both of those, MTHFR and COMT, have to do with methylation of the body.
Exactly.
And I know COMT is also associated, sometimes tested with opiate or drug addiction, alcoholism. ApoE. ApoE is something I'm passionate about, and you may have known about ApoE4, and that can be linked with Alzheimer's. But there is a normal version of it. There's actually 3 forms. There's ApoE 2, 3, and 4. But people with the ApoE4 gene tend to have a significantly increased risk for Alzheimer's, but also heart disease. And if once again, you get one from your mother, one from your father, and that's why there's 2 genes there. If you happen to be a 3-4, you are at an increased risk, but not as high.
And that's another gene that's a little modifiable. I mean, we do dietary changes. You avoid sugar, you avoid fat. There are things we can do for these genes. Genetics doesn't mean that that's the way it's going to be and there's nothing you can do about it. We don't check all the genes only because we check the genes that are modifiable. Another gene that we check is coagulation genes like factor V Leiden and factor II prothrombin gene. And why is that important?
So this could be very important if you are going to have a surgery performed or if you travel a lot for your job. It's really good for young women as well, starting birth control pills if they wanted. That we can just see if they are at increased risk of clotting, blood clots, DVTs, deep vein thrombosis.
And if they have one of these genes, I would recommend that they find an alternate form of birth control rather than something that increases the risk of blood clots.
And if traveling, then they also take lifestyle modifications, or, like get up, stretch, walk around, compression stockings. And it's definitely approachable, to change this.
So pharmacogenetic testing, that's something that was popular, then was not popular, and it's only because of insurance coverage that people aren't doing it more often. But pharmacogenetic testing actually looks at your metabolic pathways in the liver of how drugs are metabolized. And they can do pharmacogenetic testing for almost every drug out there, but it's used more so in the psychiatric world to see if someone is going to do well on a psychiatric medicine or not do well on the medicine. So you want to pick a medicine that someone metabolizes optimally, not something that they don't metabolize well, and you can avoid those. So a lot of times with psychiatric medications, it's trial and error. It's here, try this, and if you don't feel good on it, then let's try something else. But you can fine-tune it a little bit better. So I recommend most people, before they go on any psychiatric medication, have pharmacogenetic testing done.
Gut health. So tell us about a few of the tests that we do to check the gut health. I think in our practice, a big one that we like to do is the food allergy and sensitivity testing.
Right, so that's a big topic these days. Everyone's talking about gut health, and we're trying to get our microbiome as healthy as possible. So you can have allergies to foods, which are usually IgE mediated, and you can have sensitivities to foods, which are different. And you can get a sensitivity to a food just from eating too much of the same food. You expose yourself to something too often, and you're more likely to react to it. So we have a lot of patients who come to us who have vague complaints, and when we do food testing on them, we find out, hey, these are the foods you really should not be consuming too much of it. And a lot of times it's something that they're eating a lot of, right? So it'll also check IgG, IgG4, complement. It's a great test. It tells you what foods you really should avoid completely, what foods you should rotate in and out of your diet, and what foods you can eat just perfectly fine.
I mean, this goes into seeing inflammation when people feel inflamed or puffy or they're not seeing results after all the hard work they're putting into it. We can do this test. I've had somebody lose 10 pounds in 1 month from getting their gut fixed.
Exactly. A gut is huge. SIBO testing. SIBO is a big topic these days.
What does SIBO stand for?
Small intestinal bacterial overgrowth. So we have bacteria that live in our intestine, good bacteria and bad bacteria. We want the good bacteria to be predominant and maybe not so much the bad bacteria. So SIBO testing is typically a breath test, and it looks for hydrogen and methane after you consume some drink that stimulates the bacteria.
Is this meant for everybody, or is there a certain type of patient that you would decide when you want to do this test on?
No, this is a test that we use more for people who are having complaints, people who are having symptoms. And the symptoms could be many and variable, from bloating, distension, frequent belching, to digestive issues. So this is not a test we randomly check on everybody.
leaky gut testing. So I know when you have a lot of food sensitivities, that could be leading to leaky gut testing. So tell us a little bit about leaky gut.
Yeah, so leaky gut is a topic that was ignored by the mainstream medical community for the longest time, but now it's actually starting to be studied by pharmaceutical companies and gastroenterologists. In your intestines, you have a lining, which is about a cell layer thick, and those cells are right up against each other. So that's a barrier that keeps the food and the toxins and the waste products on one side of the barrier and the blood on the other side of the barrier. And typically the cells allow for the passage of nutrients. Now, when there's inflammation, chronic inflammation, autoimmune disorder, the junction between those cells gets loose because the cells are inflamed, and then you have the ability for bacteria and toxins and other things to pass into the bloodstream and cause systemic inflammation and systemic problems. So there are blood tests now that can be done for leaky gut.
Great. Microbiome testing. Now, this is something that, talking about the gut again, the bacteria in our gut, and sometimes with leaky gut syndrome, you might have too much of the bad bacteria. We have bad and good, but you always want the good to outweigh the bad, right?
The bacteria in your intestines, like a fingerprint, everyone's is different. And so you want to know which bacteria predominate if you're having problems. Again, this is not a test we do just to check it on someone. This is a test you do when you're having issues.
Celiac test. This one is interesting. So a lot of people come in and they say they want to have a celiac blood test. Tell us why that is not the best.
It's not always accurate. I mean, we see a lot of people, and also celiac disease is relatively uncommon when you compare it to gluten sensitivity, which is a completely different thing, right? So I'm more concerned, the people who have celiac disease are usually sick, they don't feel good, they usually know it, and you can diagnose them with a celiac test. But most people walking out there with gluten insensitivity, they don't have celiac disease, so the test is not going to be helpful. So most doctors are just checking the standard celiac blood test, which is not enough.
I agree. Another test that is done in the functional realm, and it's done for people, I think, when they're just not getting better, things need to be, toxicology testing should be considered. Heavy metal testing, I think that's something that is linked a lot of times with dementia or just feeling ill frequently.
Yeah, heavy metal toxicity is probably more common than we think. Once upon a time, we used to worry about lead poisoning from lead paint and things like that. We don't see that much anymore, but there's still plenty of lead in our environment. There's mercury in seafood, in fish, mercury in a lot of different things, cadmium. There's a lot of different heavy metals. So when people have unexplained symptoms and they just don't feel good and standard testing is not revealing what they're having, that's something that we might want to add to the mix and see. Maybe could it be a heavy metal, and could we find that there's something that they can do in their lifestyle?
And the same thing goes for mold testing and environmental allergy testing. I mean, we have a lot of different toxin exposures every day in our day-to-day activities that some people could be living with mold in their house. And just if you have chronic illness or inflammation and not getting well, these are things that should be considered.
Most people who have mold toxicity do not know that they have mold in their house. I mean, their houses are clean. They look fine. Sometimes they even have mold inspections that don't really show anything. But it is a problem, and we're seeing more of it these days.
So what should our listeners do if their physician does not do these testing in their office?
So I would start by having a conversation with your physician. Maybe they just don't know anything about these tests, and they're open-minded and willing to do them. Myself, I personally would not do a test on a patient unless I knew a lot about it. I would need to know how to interpret it. So if they're interested, there's great resources for them to look into it. My recommendation would be that if your primary care doctor or your physician really does not want to do the testing that we talked about, look at some of the functional medicine practices out there. We are not functional medicine, but we work closely with a lot of different functional medicine doctors. You can go on the A4M,
which is the American Academy of Anti-Aging Medicine.
And they're a good resource. They'll have names of doctors who are certified by them. And there's also the IFM.
The Institute of Functional Medicine.
Right. And so there are functional medicine doctors everywhere, and I think you can find one in your area. Another great company that's out there is called Rupa Health. Rupa Health is like a clearinghouse for lab tests. They offer all sorts of lab tests that are mainstream and out of the mainstream. You can get SIBO testing, you can get genetic testing, you can get almost anything you can think of on Rupa. You can have your doctor go in there and order the test for you, and the test will be delivered for you, and the doctor really doesn't have to get involved much at all. And Rupa also comes with something called Rupa University, where the doctors get educational resources for free for them. It doesn't cost them anything to take advantage of these and learn more about the testing that they're ordering. So the bottom line is do your homework. Take accountability for your health. Research providers in your area. Look at who's doing what. Talk to patients if they've had testing done that you're interested in. Find out who did that testing for them. I also recommend that everyone track their own lab tests, all their results. Anything you ever have done, keep a folder or scan it, but ask your doctor for a copy of your blood test when you leave the office. Make sure you have everything, because who knows, you may see 3 different doctors and they're going to have a hard time tracking down those records. And you want to track things over time, right? Your A1C, you want to see, what was it 5 years ago? What was it 2 years ago? Am I moving towards diabetes? We think that there are so many things out there, and we just scratched the surface today. I mean, I think there's probably, we could go on for another 2 hours with tests that are available.
I think we'll have some a couple podcasts on some of these individual tests down the road.
And exactly. And so, we're happy to bring this information out there. The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem, or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions, or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.